Welcome to another episode of the Nuclear Medicine and Molecular Medicine podcast. And I'm recording this at the beginning of publishing this next episode on AI and theranostics because I want to apologise for not putting up an episode for so long. I've been crazy busy working at the University of Melbourne. We're developing the next generation centiloid number, which is a centiloid process for measuring amyloid and tau in PET scans, so that the theranostics, which are coming online now, the therapeutics that are going to be slowing down and preventing Alzheimer's, will work better. We know that without a PET scan, these theranostics don't work because it's given to the wrong patient at the wrong time in the wrong dose. And so I hope that you'll accept my apology and that you'll enjoy the next podcast. And in future podcasts, we can tell you a bit more about our project. Thank you. Hi, welcome to another episode of the Nuclear Medicine and Molecular Medicine podcast. And we're going to talk to someone from Telix. And we've done this before. We've talked to Telix people before. But in this case, we're going to talk about some AI stuff related to Telix. Now, Simon Wail, Simon, tell us a bit about yourself, a little bit about Telix if people don't know what it is.
So Telix Pharmaceuticals, a radiopharmaceutical company. We have various drug tracers for cancer imaging and theranostics, so for therapy in cancer treatment. Some have been approved for sort of commercial sale, and others are in the pipeline of clinical trials.
Right. So what you presented today was ways of using AI to process PET scans. What were the PET scans of?
These was of prostate cancer patients, so imaging of the prostate gland itself and with cancerous lesions within the prostate.
So these were PET-CT scans?
Yeah, PET-CT, yeah.
Right, and so what was the goal of the AI in this situation?
So the goal of the AI here was around precision medicine, and can we use AI to help predict the risk of high-grade or low-grade cancer. So in prostate cancer, when it's early in the diagnosis stage, patients are either put on active surveillance, where it's sort of a watch and wait scenario, or if it's considered a high-risk cancer, then normally they go for some sort of therapy, which probably is surgery to remove the prostate.
Right. And so how do they determine whether it's high risk or low risk during current management?
In current management, that's normally through a biopsy. And so, basically putting a needle through the skin and to withdraw some cells from the prostate. And unfortunately, given the location and the way these biopsies are done, you can't always identify and get cells and tissue from the actual cancerous lesions. You need some sort of image guidance to help you to do that.
So did you do image guidance to do that?
Yeah, there is MRI imaging that is often done prior to the biopsy. But again, when you've actually got the body in a different location and you've got the needles, you need to try and match that with the MRI, and that's often a difficult thing to do because you normally only have ultrasound at that point to guide you. There are techniques that are quite complex where you can register the MRI image with the ultrasound as you're doing the biopsies, but that's not sort of standard clinical practice at this point.
Right. So these biopsies are not always accurate. That's what you're trying to say.
That's correct. Yeah. Yeah.
How accurate are they?
Well, if there's no image guidance, studies have shown that they're about 60% or 65% accurate. When you've got image guidance involved with sort of MRI, it normally goes up to about 65-75%.
75%, okay. So you used a deep learning algorithm, was it? A combination of deep learning, machine learning algorithm?
A combination of deep learning and radiomics, or shallow radiomics. So the deep learning was around determining the prostate gland itself from the MR or the CT image, and then using that to then mask the PET image to identify the lesions within the prostate itself, the cancerous lesions or the suspected cancerous lesions.
Right. So you had that, but then how did you validate that that was the correct thing?
In terms of the AI algorithm?
Yes.
So we currently only have a single site data set, so
Right.
it's still early days. So we had a data set for training, and then we had a separate data set that we used for testing with a high quality ground truth. So that was actually based on histopathology. So once the prostate is removed,
Right.
you actually can definitively have that cancerous tissue graded.
So you had a gold standard. You
Yeah.
didn't have the biopsies, the gold standard. You had the removal of the prostate.
Yeah.
And then you tried to compare how accurate just doing the scan was with AI
Yeah.
to figure out whether it was high grade or not. So
That's correct, yeah.
So what was it?
Well, it varies from patient to patient. Some have been found to be the AI is more accurate than the initial biopsy.
Yes.
And in other cases, it sort of confirms the biopsy. So our sensitivity and specificity was, of memory, 88% sensitive and 82% specific.
But hold on, that's better than the biopsy, isn't it?
Well, yes, it is, but we're not going to. We're single site. We need to collect more validation data, ideally more training data to really sort of build it
Right,
into
and I guess the single site, presumably this is a relatively a centre of excellence, was it, for that? So what was the site?
It was the Medical University of Vienna.
Right.
So they're, they have lots of prostate cancers scans, and it was all validated by nuclear med physicians and neurologists,
Right.
In terms of getting the gold standard results.
Right. So that meant that you could almost replace the biopsy with the PET scan, right?
Maybe.
Right. You need to have more sites. You need to have more
Yeah.
data before you can be sure about that, right?
And also the PSMA PET tracers are not currently validated or approved for initial diagnosis. So,
Right. So what tracer did you use?
So this was the PSMA 11.
Okay, so that's a good one, right?
Well, yes, it is, given that Telix has that as its primary commercial product at the moment,
Right.
as Illuccix.
Right. So this is great. I mean, if down the track you prove it, then you're going to improve the patient's outcome because you're not going to misdiagnose people by a biopsy. Yeah, that's incorrect. And secondly, they're going to avoid a biopsy.
That's the ultimate goals. Yeah.
Right. So that's amazing. That's great work. What do you think your AI used to work that out?
It's interesting because we actually use what's called radiomics, and that's really taking the imaging data and going beyond just what you see visually, but looking at it more of a mathematical intensity. So taking things like the shape, the textures,
Gotcha.
Histogram of intensity, those sorts of information, but getting more into the details, and this has actually been standardized by a group. It's the Imaging Biomarker Standardization Initiative that is identified and standardized about 100 to 200 standard biomarkers that essentially are a mathematical equation to the imaging data.
Right. So it's more than SUV mean and SUV max,
Yes.
right?
Yeah.
So AI is smart enough to use. It obviously can work out SUV and SU max,
Yeah.
but it can probably work out other things as well, right?
Yeah, and our AI platform is something that's sort of automated machine learning. So we're able to throw it images and it extracts the radiomics automatically, and then it will look at all the different radiomic features and rank them in sort of terms of their correlation to the end predicted result as part of its training. And so we then have a list of, the top 10 or 20 radiomic features that strongly correlate to the predicted outcome.
Okay, I'm going to ask you the standard question you always ask in AI. How generalizable is this? I mean, is it only it's very hard in AI, particularly deep learning, to generalise it. It'll
Yeah.
work fine on one machine with one set of reconstruction, with one set of
Yeah.
PET scanners, with one set of traces. How generalisable is this, and what's your answer?
Well, it's something that we're working on at the moment.
Right.
We have found with some initial multi-site data that the results are not as good as the single site.
Right.
And that's one of the reasons we're trying to get more data to train and to validate our models, because you need to get that multi-site, because in PET imaging, probably more so than some of the other radiological imaging, that there's a broad difference in the scanners, their image quality, their reconstruction, as you mentioned.
Indeed.
And so you need to collect as much data as you can with as much variability to really build a robust model.
Yeah, or you need to filter your input data and say, look, this is only generalisable to this subset of scanners, this subset of trace. You can't use it on everything, right? You can't use it on everything. Garbage in, garbage out. There's a bit of that?
Yeah, well, absolutely. Yeah, there might be some scanners that you want to do that with, because they might not have like the standard imaging parameters, or they might hide some of their reconstruction information, so it becomes a little bit more difficult to really understand the data that they're producing. But ultimately, we'd like to avoid that sort of limitations.
You'd like to make it as generalisable as possible.
Absolutely.
But you do that by increasing your data set size, right?
Yeah.
So you need other people to collaborate with you, don't you?
Yes, absolutely.
Is that what you're going to ask for here?
Give me data.
Right.
I'm always looking for more data.
Sure. Well, I mean, we're talking about now a very common technique, right?
Yes.
And you've got a very widespread product that's available pretty much around the world, right?
We're getting there.
Yeah. So you should be able to get a lot of data. You should be able to get a lot of sites. I mean, in Australia and New Zealand, we've been using this stuff, and Telix is really good here for quite a long time. So we've got a lot of data here, but we're a population of only 25 million, right?
Yeah.
Europe's bigger. United States is bigger. You should be able to get a huge data set. With a huge data set, you can make it more generalisable, right?
Absolutely. But it's not as simple as just saying, give me data, because as a commercial entity, we have to make commercial agreements to obtain this sort of data.
Right.
It's not academic research where everybody tends to be happy to share data quite easily.
Right.
Commercial entities, it's not as easy as that.
But we're working our way towards it.
Yeah, we're working our way. We're getting there.
Well, this is fantastic. I mean, this is a situation where you potentially will improve the outcome of patients and also reduce the morbidity of patients by not having them have that. We just need a bit more work to get there, but it's pointing in the right direction.
Absolutely. Yeah, that's some of our goals, to really benefit the patients, benefit the clinicians, help them make the right decisions for the best outcomes for the patients.
And is there anything else you'd want to add while we're on the podcast about that?
To
thank?
Well, I need to thank, the team at Medical University of Vienna. They started this work. They then spun it out into a company called Dedicate,
yes.
Which Telix has since acquired last year.
Yeah.
And we've been working very closely with them to sort of continue the work that they started and to move it into the commercial market is ultimately the goal.
All right. Well, thanks for joining us in beautiful Christchurch.
Yes, it's a beautiful sunny day.
And it's a beautiful sunny day here. And Christchurch is an amazing city. It's very different to when I saw it last time. Last time I saw it was before the earthquake.
Oh, okay.
Yeah,
but, a while ago.
Yeah, that was a while ago. But yeah, thank you for joining us and thank you for taking part in the podcast.
Thank you.